Thank you all for joining us for today's webinar, Cervical Cancer Screening Guidelines for Diverse Populations. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link in the webinar's chat box. You can also use this box to enter questions throughout the webinar, which our presenter will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borthwith, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre- and post-test, as well as the follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your feedback. At this time, I would like to introduce Nicole Gettings, today's presenter. Nicole has been providing comprehensive reproductive health services in the heart of Midtown Memphis for 10 years. She has a master's in nursing from Vanderbilt University School of Nursing and is a certified nurse midwife with board certification from the American College of Nurse Midwives. Nicole offers a unique set of subspecialty skills within the field of gynecology and reproductive health that are not widely available in the Memphis and Shelby County area, including care for individuals who identify as transgender, same-sex fertility assistance, fertility evaluations for men and women, men's reproductive health services, adolescent reproductive health, HIV prevention, including PrEP and PEP, and reproductive health services for HIV-positive patients and their families. She's also a speaker and educator and provides lectures across a broad array of reproductive and sexual health specialties to other clinicians throughout the United States. We're thrilled to have her with us today, and I will hand it over to her. Nicole, you have the floor.
Thanks so much, Jessica, for that lovely introduction. And I just really appreciate the opportunity to work with ARHP, who ARHP has worked so hard to really disseminate lots of great education and information for providers who are out here in the field, and I'm glad to work with them on this project. So this project was made possible through Roche. Roche is a company who makes HPV tests. And of course, we're going to talk about some of HPV tests and their applicability and usefulness in clinical guidance with Pap and cervical cancer screening. So we are grateful for their collaboration and funding that makes this education session possible. I also worked with a group of individuals who helped as a committee to create this PowerPoint, as well as another module that will be released later this month, also dealing with cervical cancer. And we have no relevant, none of us on this committee have any relevant disclosures to make. All right, so the learning objectives, I'm not going to read through those. I think you guys can certainly read your screen there. I will say it's a lot of content to cover in a fairly short amount of time. And so there are going to be some topics that I'm going to run through fairly briefly. Of course, your citations and references are there for you to do follow-up if you want. Also, I will say there are a couple of resources ARHP has been developing in conjunction with this project. One of them is another webinar module that I mentioned a moment ago. It focuses on cervical cancer screening in vulnerable and underserved populations. As a component of that, sexual and gender minorities certainly are part of that. However, it also looks at HIV-infected folks more in depth than this one will, as well as individuals like homeless individuals and organ donor recipients. So be sure to be on the lookout for that. Also, as part of this project, ARHP has developed two podcasts on cervical cancer screening. We released one last week. It's a 15-minute podcast that you can go online and listen to. You don't have to log on at a specific time. And that also comes with CME credits. And the one that was released last week is on transgender populations and cervical cancer screening. We were very honored to have a patient join us for that conversation and really gave some great insight into how to best provide care for transgender individuals in regards to their cervical cancer screening needs. All right. So to get us started, I want to pause for just a minute and make sure we're all on the same page in regards to how we define sexual and gender minorities. You know, in this day and age and in the media, we certainly see some of these terms a lot more frequently than, say, even 20 or 30 or 50 years ago. And I want to make sure that we are all on the same page with this definition. So the populations we're going to talk about today are namely lesbian population and transgender individuals, with most of our focus on transgender individuals who are female to male, so they still retain their cervix. Again, that second module will address a little bit further into neovaginas and transgender individuals who've had reconstructive surgeries to create their vagina. Many people look at kind of identity and sexuality and gender as things that are shown here in this model you see on your screen, that definitely they're interconnected, but they may be independent of each other. So in other words, kind of to put that in practical terms, you may have a lesbian who is identifies as a lesbian, but she's either currently or has been in the past in a relationship where she was with a heterosexual male. And so sometimes these things just happen, and sometimes each of us are growing and transitioning and learning more about our own selves and how we identify, and also how we want to incorporate the relationships and sexual behaviors that go with that identity. Gender language is one that we really want to kind of define real explicitly. So sex specifically refers to attributes that characterize biologic maleness or femaleness. So this is what we're born natally with. It's certainly the physical and genetic, so it includes sex-determining genes, sex chromosomes, the HY antigen, gonads, sex hormones, and of course the internal and external genitalia, as well as the secondary sex characteristics. So the second term here is gender identity, and that's really a person's core sense of how they identify, whether it's male or female or indeterminate. Also another term for that is non-binary. And their gender identity may in fact not match those other things that we just talked about in regards to their sex. We need to understand that for transgender individuals, this is a transition. Transgender literally means to bridge, and it's a trajectory. That trajectory may be fairly short. It may be long, and in fact may span over several years. It may involve hormone treatment, it may not. It may involve surgeries or reconstructive surgeries, it may not. The important thing is that a transgender individual, their core sense of their gender identity does not change. Studies have shown this over and over again. But their transition, their trajectory from going from how they identify in their core sense of gender to how they pass or what's apparent to others may span a long period of time and may involve different things for different people. Intersex population is a population that I wish I had more time to spend on. I'm just going to mention it very briefly. Intersex conditions are congenital, meaning they're natal, developed during fetal development, and they are a condition that impacts the chromosomal, gonadal, and anatomic or phenotypic is another way to think about it, genitalia, in a way that causes atypical development in those three different areas. Intersex individuals, we know that there are lots and lots of different diagnoses. Those diagnoses fall in a couple of different categories. So of course there's some like Turner syndrome or Klinefelter syndrome that are genetic aberrations or abnormal genetic development that then leads to abnormal internal and external genitalia and gonads. However, others of them are impacted, such as androgen insensitivity syndrome or some of the partial androgen insensitivity syndromes, are impacted by hormone exposure during the mother's pregnancy that then impact the development of that fetus in regards to both their gonads and their phenotypic genitalia. I want to go back to the intersex individuals for just 1 second and just say the main thing to keep in mind in regards to this lecture for intersex individuals is that many people may have a cervix even if they cannot ultimately get pregnant. Some intersex individuals can, some intersex individuals cannot. It depends on the situation, the specific diagnosis. And intersex individuals certainly are people like all of us. They have a sexuality, and they're not less at risk for HPV, as we're going to talk about in just a minute. So you need to, even though you're not going to find guidelines specifically mentioning intersex individuals, if an individual has a cervix, then you need to be doing cervical screening as you would with anyone. So how many people are we talking about when we mention this sexual and gender minority? So unfortunately, here in the United States, we have a long history of really not addressing surveying or collecting statistics. Both those questions were not included on the surveyor end, but also it was very difficult to get people to identify. And certainly we have seen several changes, some of it starting with a publication called Injustice at Every Turn that impacted the surveys themselves, that have increased the number of questions that address asking individuals to identify. We still acknowledge that we have a problem with statistics when it comes to some people are not going to feel free to identify as a specific sexuality or gender that's less than, or I should say, different than the accepted norm. But even so, these small changes have led to organizations like the Gates Foundation, which is based at the law school at USC LA, to be able to start to grapple with some of the numbers we're talking about. And here in the United States, in 2011, Gates was able to feel pretty confident estimating about 9 million people, just a little bit under 9 million people here in the U.S. who identify as LGBT. And when you look at intersex individuals, and this data comes from some 1998 publications, however, is supported by the Accordance Alliance, which is an organization that is an online site that is for support of intersex individuals. And again, sometimes there are problems with accounting for intersex individuals. Some folks are never diagnosed at birth. Certainly externally they look normal. We're not doing an internal exam. And it's only when they go on into puberty and those secondary sex characteristics don't develop in the way that we would expect them to that we may do some more investigation. And then for some people it's even beyond puberty. It may go on into their adulthood and they only have an investigation when they're encountering fertility problems. But our best guess is that about 1 in 500 is certainly possible, although it's maybe closer to 1 in 2,000. Either way, that's a pretty large number. It certainly happens more commonly than many people assume. All right. So we're going to kind of switch topics here and talk about HPV itself. And before we talk about this, I want you to think about the question of, you know, in regards to HPV and how many people get HPV, and if you can be thinking about what you know or may guess about that. We know from research that in both heterosexual men and women, studies have been published for quite some time now that show prevalence of about 50 to 80%. So that's the large majority of people are infected with HPV at some point in their lifetime. And it's a large majority of people, and by the way, their worldwide prevalence is equal, so it's not necessarily specific to the U.S. But if so many of a majority of people are infected with HPV, then do we need to worry about that infection itself? And the answer would seem, if you're looking at this slide, to indicate, well, yes, HPV is associated with these big, scary things like cancer, and so of course we should be worried. Now, hopefully, by the time we finish here, you're going to feel a little bit differently in regards to that answer. The answer should be something along the lines of, no, most of the time we actually don't worry about the HPV infection itself, but we acknowledge HPV is connected to these cancers, and there may be things that you can do to decrease your risk of developing cancer, even though you are likely to be infected with HPV, and we're going to talk through some of that. All right, and so that kind of leads to the next topic, which is sort of what's the natural history of how does HPV end up resulting in cervical cancer and some of the other cancers that we looked at there. So one, let's start with how is HPV transmitted. So we know that HPV is in fact skin-to-skin contact and friction. And of course, folks who rely on just the media or even research may be a bit surprised about that. They tend to think that certainly all you'll see in the media publication is that HPV is STI or sexually transmitted. And instead, I want you to kind of think about the fact that sexual transmission of HPV, although true, has more to do with the fact that sexual activity is something that certainly involves skin-to-skin contact and friction. And so any sexual activity has the possibility of passing on HPV, but we know that HPV is passed many other ways. Certainly, if you can think about all the ways that you have skin-to-skin contact and friction, those are, I hope, not exclusive to sexual activity. And so why are we concerned about sexual activity in HPV, and is there any connection there? And the connection there, yes, we know that there's a large prevalence. That's certainly true. The connection, though, is about location. So I want you to think for a minute about some similarities between, for example, the mouth and the vagina. The biggest similarity is that they're both made up of skin cells that have a special function, and those special function skin cells are called mucosal skin cells. We also have mucosal skin cells inside our nose, certainly, inside of our mouth, as I mentioned, our vagina, our anus, around the urethra for men. Those are all areas that you're going to find these mucosal skin cells. These are softer skin cells, and by softer, I really mean that their actual cell wall is softer. And it's these special mucosal skin cells that are the most vulnerable to infection with HPV in regards to the types that we know are most highly correlated with cancer. There's another location that is important, and that's the transformation zone. So what's this transformation zone? The transformation zone is an even more specialized area of skin cells, and it's unique in that the transformation zones, and we have a couple in our body, are an area where the skin cells are actually differentiating. They're deciding from their initial creation as a skin cell what kind of skin cell they're going to be. And at the transformation zone, in either your cervix or a little bit inside your anus or at the back of your mouth at your tonsils, those are transformation zones where skin cells are determining whether they're going to be something called squamous skin cells or columnar skin cells. And it's that point that you're the most vulnerable. There's a couple of reasons you're the most vulnerable, but there's also a couple of reasons that those areas kind of build some natural resistance to HPV. So some of the areas have to do with the softness of the skin wall and less keratin. Some of the defenses your body has is because those areas are soft and moist, they have high skin turnover. And so sometimes HPV infects a skin cell, but that skin cell is shed or gotten rid of because of the high turnover in those specific areas. So those are some things that contribute to why HPV in these specific locations leads to sometimes cancer. Another big thing is time. So we know that high prevalence of HPV, it takes about 4 to 20 months or about 2 years. 90% of people will have gotten rid of that original HPV infection. Now, we'll start talking a little bit more about genotypes in just a few minutes. And what we know is that there's about 150, probably more, genotypes of HPV. Only a few of those are associated with cancer, and then a whole lot of them are associated Only a few are associated with something we can visibly see, like a wart, and then a whole lot of them are actually associated with changes in our skin that we can't see and that don't seem to have any negative impact that we know of today. So we're going to talk more about those genotypes, but the relevance here to this slide of the genotypes is in regards to that persistent infection. So it's possible for you to have one type of HPV and have another type at the same time. It's also possible that at one point in your life you'll have an HPV infection with one genotype, and then later in your life you'll have another infection. So they can happen both concurrently and sequentially, if you will, although that's not a great term for it. HPV-16, that's one of the special genotypes that we'll talk some more about, is specifically more likely to prove persistent. However, it also, strangely enough, is the one that's most prevalent. So that's some interesting, sometimes can be confusing data. All right, so what HPVs have been determined to have specifically been causal for cervical cancer? So the top row there, the 16, 18, goes all the way to 59. The International Agency for Research on Cancer released a monograph in 2009. I believe that's correct. I was just double checking that reference there. They released that monograph in 2009 saying that definitively from their review of all of the worldwide cases of cervical cancer, and in fact sometimes they even pulled those tissue samples and did additional testing, they can definitively say that 99.9% of cervical cancer is related to one of those on that top row. Out of that, about 70% are believed to be associated with the first two, which are types 16 and 18. Many of you may be familiar with that from the HPV vaccines that have been released in the last few years. Certainly, starting with the first quadrivalent one, it contained vaccine for 16 and 18. And then the 9-valent one, we'll talk about in a minute, includes all of these HPVs that you see listed on the top row, except for one. That one causes a very minor amount, so less than 1%, but it's still not all of them. All right, so if a large number of people get HPV and a few number of people, we also know that location is important. We've talked about time being important. The last factor is kind of an interesting one in that it's really about you. So it's about your immune system, and it's also about your behaviors. So some of you may be surprised to see some of these boxes up here, that we know that HPV progresses to cervical cancer when there are some of these cofactors present. So again, the International Agency for Research on Cancer, in that same monograph I talked about just a moment ago, did determine that these are cofactors that when paired with HPV lead to higher risk of progression to cervical cancer. I'm not going to be able to go into depth today about the mechanism of action for this, but we do know that tobacco use and long-term, meaning more than 5 years, of continuous oral contraceptive use, as well as some immune system disorders, and high parity, so more than 7 full-term pregnancies. Some of you may not realize that these are behaviors we know absolutely are associated with HPV-related cervical cancer. And what I think is particularly relevant here is that these are areas that you can spend some of your valuable time addressing with your clients and finding ways to reduce their risk related to these kind of behavior-related mechanisms. All right, so we've talked about all these different factors. First, you've got to have that HPV infection, which almost everyone does. Then that HPV has to stick around a long time, which very few do. And then the HPV has to be in the right location. And then finally, those cofactors we just addressed. And if you add all of those things together, then sometimes you end up with cancer that is almost always specifically related to HPV. So about how much of the time does that happen? Well, here in the U.S., we've been able to greatly reduce those numbers by secondary prevention that we're going to talk about in a few minutes. But we still have about 12,000 cases in the U.S. annually. We have about 4,000 deaths in the U.S. And certainly when you broaden that picture out to worldwide numbers, those numbers do get quite a bit larger. We've talked just briefly about other types of cancers that are associated with HPV, and you can see those here on your screen. I think the most important thing is, I've mentioned several times that cervical cancer, we know that 99.9, so almost all cervical cancer is related to HPV. However, if you look at these other areas of the body, so penile cancer, only 40% of those cancers are related to HPV. This is similar to vulva and vaginal. So some of the key things about that are why I talked so long earlier about the nature of skin cells. So those more external, more keratinized skin cells seem to have some built-in defenses against either the persistent, the long-time infection, or even possibly it has to do with the fact that the transformation zone cells are at a more vulnerable stage in regards to their DNA because they're differentiating between two different types of skin cells. Whereas those external skin cells on the outside of your body are not doing that. They have already differentiated. When you look at anal cancer, so there you do have a little bit closer, but not completely, correlation with cervical cancer. About 90% of those are caused by HPV. When you look at the mouth and the oropharynx, you get down to much smaller numbers, only about 3% of mouth and about 12% of oropharynx. I will say that conjunctiva, so the eyes, we did see that earlier on the slide, is similar to the mouth in about 3% of cases. All right, so what do we do about HPV, and how can we screen, and how can we potentially treat or prevent cancers associated with HPV from developing? We're going to go through this section really quickly. The next two sections actually on both the vaccine prevention and on the cervical screening. All right, so starting in 2006, we saw the first HPV vaccines. That was the quadrivalent. It protected against 16 and 18 as well as 6 and 11, which emerged out on the market. We then saw that develop a little bit over time. So in 2009, we had both a quadrivalent, but we also had a bivalent. That bivalent only addressed the genotype specific to cervical cancer. And then in 2014, we saw the advent of HPV-9 be released. So this includes, that's where I said this includes, you'll see those numbers there, 16, 18, 31, etc. The only one you won't see there is number 59, which was on that top row of that slide we looked at earlier. And of course, 6 and 11 are actually not associated with cancer, they're associated with genital warts. And then as of 2016, in fact, sometime in the last quarter of 2016, the only HPV vaccine currently available in the USA is the 9-valent. You cannot obtain the HPV-4 or the HPV-2 anymore here in the US. Worldwide, that's not true. Some other countries still have those accessible. And so along with that development and release onto the market of the actual vaccine are kind of guidelines for their use. And of course, the American Council on Immunization Practices is the organization that governs and releases that data in conjunction with the CDC. Of course, right in 2006, right after the HPV-4 was released, you saw those first guidelines. The initial guidelines were based on the FDA approval of that first HPV-4 that was only FDA approved for girls. And of course, immediately in the real world with providers, but also with researchers who knew that HPV infected boys as well, there was immediately an outcry and sort of why is this so? It had more to do with how the approval was originally submitted. You see that change in 2009 when the makers of the vaccine, particularly the HPV-4, went ahead and applied to the FDA for permission to broaden that authorization for use, and you saw the subsequent ACIP recommendations, including boys. However, they initially were very cautious about that in that they didn't recommend it routinely. They just said it was permissive or it may be given. We'll talk about that in a minute in regards to the current guidelines and how that impacts coverage for them. And then every couple of years, you'll have seen that there was a little change in either the data or how they stated the recommendation. They did eventually say it should be routine for both boys and girls starting at 11 or 12. In 2014, they in fact included starting younger for victims of sexual assault. And then in 2016, we're going to look at that a little deeper because they've made some really great changes in a couple of different ways. So what you see here is kind of an abbreviated version of the ACIP recommendation that was just released in December. And this is the first time that you'll notice there on the doses that for our age categories 11 to 14, for both females and males, that we only need to do 2 doses. And I certainly can remember sitting at one of those first education meetings in 2006. I had just graduated and was just starting to practice as a young clinician. And I remember raising my hand and saying, so I work with uninsured and underinsured population, and I'm just wondering if we're ever going to see the recommended dosage down to less than the recommended 3 doses. And at that time, they really couldn't imagine that that would eventually develop. But it has developed, and it developed really because of that question that I asked, because people had difficulty sometimes affording all 3 doses, but also getting people to come at that age group for all of those visits was burdensome, and often people didn't finish that dosing schedule. Now, why do we continue to recommend for some populations that they continue with the 3? So you'll notice if we start that vaccine after age 15, and that has to do with the immune response. So in the data that is presented in that ACIP recommendation, again, December 2016, they explain it very well. They go into great depth to show you that the 2 doses is equal or as effective in 11 to 14, or even younger in the case of 9. But after age 15, there's something that changes about our immune response, and in fact is a less robust response. So if we don't start till 15, they are still recommending the 3 doses. And then the other thing they added in 2016 is transgender. So they make special notice of this, and I really am proud of them as an organization for going ahead and putting this in here. They talk about transgender individuals in 2 different ways. One, for adolescents, they just remind you that transgender adolescents fall into the same recommendation as all adolescents that we just talked about, and that it should be routine at 11 or 12. Also for transgender, though, they talk about a difference in the age 21 to 26. So for both MSM and for transgender, the recommendation is all the way up to age 26, just like it is for females. The reason that is specific to MSM and transgender is because of high HIV infection. Now, I should say there's a caveat to that. The high HIV infection in transgender individuals is in fact higher than in MSM, but only for our male to female transgender individuals. So only in the male to female do you see it somewhere between a 50, so 1 in 2, to a 75%, so 3 out of 4 infection with HIV in the male to female transgender population. And that's why with that HIV infection we see increased anal cancer, and that is why that they are continuing to recommend that routine vaccination all the way up to age 26. For men who do not fall in those categories of either MSM or transgender, we still are at that permissive vaccine. And what does that mean? That really means that you can give it, but their insurance is not likely to cover it. And I can tell you I've called and checked on that for several of my patients who have wanted to get it between that 21 to 26, and they simply won't offer to cover it. The patient can, of course, pay for it out of pocket, and I've had some patients opt to do that. And so ACIP covers that by saying it may be given, but it's not routinely recommended. All right, so now we're going to move on to secondary prevention and screening tests, and that's our Pap and Cytology. So, even though this timeline starts in 1980, the reality is that Dr. Papanicolaou recognized way back in 1928 that it was possible to look under a slide and look at cervical skin cells and determine, based on abnormal size, shape, or number, that there was some predictive value in regards to abnormalities in size, shape, or number, and whether or not that woman might be at risk for cervical cancer. However, there wasn't a lot of support for this idea at that time, and it was a little more than 10 years that he set that research aside, and it was only in 1945, so really close to almost 20 years, that the American Cancer Society began initially promoting some Pap, but there really wasn't wide uptake of that. So it was really in 1980 that the American Cancer Society, they in fact, what's interesting now is that their original recommendation was a Pap every 3 years. So it's interesting that those guidelines, and we'll talk about those in a minute, have now sort of, that were in 1980, are now the ones that we've gone back to since then. And of course, since then, there's been several changes, and we're going to focus mostly on the most recent changes in 2012. The 2015 box that you see there is really about some of these other organizations. So in 2012, ASCCP officially released the data and also their recommendations based on that data. Since then, all the way through, even ACOG released some new data in 2016 on HIV-infected women. Since then, these other organizations, American Society for Cancer and ACOG, have updated their guidelines to be mostly more in line with those 2012 guidelines. Okay, so this is the part where I'm going to start speeding up because I do want to get to our specific population of interest. So in regards to Pap Test or Cytology, you can see here on your screen that you've got a couple of different results that can come back. So you can get normal, ASCCP, LSIL. By the way, for ASCCP, I always tell folks you can translate that into ASCCP to look closer. LSIL, HSIL, and we know, starting with Dr. Papanicolaou's original data, we know that when we get a cytology report from the pathology, it's looking at abnormal size, shape, or number, and really the Pap is telling us that it's possible these abnormal size, shape, or number could indicate a cancerous lesion or a potentially high probability that a cancerous lesion will develop. But we also know that women's bodies, and we're going to focus on cervix here, so I'll talk about women's bodies, they can also basically shed these abnormal cells in these abnormal areas. And so you can have someone who gets an HSIL Pap, and that may not mean that she has cancer, and certainly it may spontaneously resolve. And there are certain populations, particularly young women, that, so 21 to 29, that in fact that's more likely than not to occur. So there's nothing we need to do, there's nothing we need to treat, and recognizing that these results are not the same as histology results, which we're going to talk about in a minute, that are actually cancer. Okay. Now it is possible, although I will tell you in 10 years I've never had a pathologist send me a Pap report back as cancer, but it is potentially possible. That is an option they could choose. It's just very rare that you're going to see that. That pathologist is more likely to wait on the histology to come before determining that. In addition to your cervical test, of course, I'm sorry, your cervical swab, we've got HPV testing. And we're going to talk about ways that these two things can be joined. I really encourage you to contact your lab when you use HPV testing. So there's only a few listed here on the screen. That is not all of the ones that are out in the market and available for labs to utilize. And labs, in fact, are not required to utilize FDA-approved HPV tests. They can do their own internal testing to prove validity of a test, and they can choose to use one that may not be FDA-approved, but is still valid to an extent, and we're going to talk about what does that extent mean. It means that they may be, for example, sending you a report that includes genotyping on the low-risk and the high-risk HPV. Well, clinically, I don't need any of that information, and there's no validity in giving me that information. It doesn't change what I'm going to do in response to that. So except for in a few cases, most of the time, all the information that is valid is whether it's high risk or low risk. And you don't need to know any additional data regarding the genotyping. If you are going to get genotyping, the only valid use that there are any clinical recommendations for are only in regards to HPV 16 and 18. So any other genotyping doesn't have any relevance in regards to clinical decision making at this point in time. Now that doesn't mean that data won't come along later that will change. Why do we use HPV testing? Of course, we want to stratify risk. We can certainly see who's more or less likely. So if we have an abnormal Pap, the HPV is negative, we can feel very confident that she's not likely to develop cervical cancer within a certain time. And but we can also utilize it to tell us whether someone needs more frequent screening or scrutiny. What can we not use HPV for? So HPV testing certainly is not for STI testing. It's not to determine whether someone should or should not get the vaccine. We're going to go through a couple of the algorithms in regards to ASCCP's guidance on how to use HPV. So your Pap and your HPV testing, and then sometimes you end up needing to do a colposcopy with a biopsy, and then that leads to histology findings. And you'll see here that CIN, the histology or biopsy findings could be CIN 1, 2, 2, 3 is still a category that you will sometimes see and certainly historically saw more often, and CIN 3, and then you can actually have cancer. And then of the cancers, there's two different types, AIS and SCC, or squamous cell carcinoma. The squamous cell carcinoma is by and far the much more prevalent one. AIS is a much more rare cancer. And then again, you'll see these arrows. So we know that CIN1 and CIN2 can spontaneously resolve. We may not need to treat that at all. CIN3 can potentially spontaneously resolve. However, it is the consensus point that we say we're going to go ahead and treat as if it's cancer. And it is important to remember, it is not cancer at CIN1, 2, or 3, but only is it likely to proceed and develop into cancer. If you do get a cancer finding, that is absolutely cancer. All right, so what are our current screening recommendations? We want to, utilize appropriate screening to identify and treat those high-grade precursors that are not cancer. It's important not to counsel your patients that they have cancer if they just have one of these precursors. We also want to avoid unnecessary and harmful treatment. And we also want to minimize both healthcare system costs, but also the cost to the woman herself in regards to healthcare expense, but also in regards to worry and anxiety. And then the other piece that is not included on here is sort of why did this harm become more of a concern? And it became more of a concern preceding the ASCCP's 2012 guidelines in regards to harm that they did have definitive proof showing that when we were treating these precursors more aggressively and too aggressively, that we were increasing the preterm delivery rate. And if we were increasing preterm delivery rate on lesions that were never going to become cervical cancer, we were in essence increasing morbidity and mortality of both infants and their mothers for something that was not necessary to do or to treat. And so we do want to minimize those costs all the way around. In their 2012 guidelines, the biggest thing was ASCCP actually returned to that previous AFC guideline in that no woman should be screened annually. Women should be screened in what they define as routine screening, which is based on age and clinical history. And here are those recommendations. So we no longer start any kind of Pap before age 21, regardless of sexual history, regardless of when they start having sex. Between 21 and 29, we're only going to do a Pap every 3 years. And in almost no cases HPV testing of any use in that population, because we know the prevalence is very high and it doesn't have much clear causality at that point. Over age 30, we can do co-testing with both the Pap and HPV, and then that woman only needs testing every 5 years if her HPV is negative. If you're only using the Pap, you need to stay with that same routine every 3 years you saw in the 21 to 29. And of course, stopping screening after 65, and of course, after a hysterectomy, as long as the cervix is removed. There are some separate guidelines if she had a hysterectomy specifically as a result of true cervical cancer. NCC releases those guidelines if you're interested in looking further into that. All right, so we're going to spend just a few minutes going through these slides on what to do if, and in regards to HPV testing and cervical cancer. So if you get a Pap which is unsatisfactory, so that means that there aren't enough cells present for the pathologist to make a determination. If the woman is in any age category, so 21 to 65, and that's your result, and you do not have HPV results, then you want to repeat that cytology and try to get a better sample at 2 to 4 months. If that woman is over age 30, you have a couple of options. You can either choose HPV testing at that point. If it's negative, the same recommendation, just go ahead and try to repeat that Pap. If it's positive, you could choose to go on and do a colposcopy to get a better look at her cervix to understand what may be going on there. In a situation where the pathologist had enough cells to determine that it was satisfactory, but there were no endocervical or transformation zone cells included in that Pap sample. For young women between 21 and 29, there's no rationale for doing HPV testing, and in fact, there's no rationale for increased scrutiny. Just return them to their routine every 3-year screening. For women over age 30, you have a couple of options. One is you can just do plain HPV testing, no genotype, and if the HPV testing for high risk is negative, then she can go back to routine testing. If it's positive, you have a couple of choices. You can either repeat that co-test more sooner at 12 months, or you can rely on genotyping of HPV 16 or 18. In the case that you have a satisfactory transformation or endocervical cells present and it's a normal Pap, for women over age 30, as we mentioned, you can do that HPV testing. If her high-risk HPV is positive, you want to repeat that co-testing at 12 months. If it's negative, then she can safely return to that routine screening. In the situation where a woman has a satisfactory, plenty of endocervical cells present, normal Pap, but HPV is positive, this is where you can get into that HPV genotyping. So you can utilize HPV genotyping if and only if 16 and 18 are negative. Just repeat that co-testing at 12 months. If it's positive, you do want to progress on to a colposcopy to get a better look and possibly a biopsy. This is the only situation in which HPV can be used in those young, that young age group. So in women aged 21 to 24, if you utilize HPV testing, if they have an ASCCP or LSIL, you can determine whether you need to repeat that testing at 12 months, or she can safely return to routine screening in the case of high-risk HPV being negative. There are a few populations. So in 2012, ASCCP guidelines officially said that immunosuppressed patients, and they not only said this, but they presented the data supporting this, that immunosuppressed patients should not be treated differently than women in that normal age and clinical history category. So they did not make separate recommendations for HIV-infected individuals, for example. Now, other organizations such as ACOG, they just updated their 2016 recommendations for HIV-infected women, and they're still relying on some previous recommendations, although they don't provide much data supporting this in regards to an increased scrutiny from the time of HIV infection for the first 3 years. And if all of those are normal, then she can transition to those routine screening categories as defined by ASCCP. Of course, if the woman has had a previous diagnosis of CIN2, 2, 3, or 3, and of course cancer, keeping in mind that if she's had cancer, and true cancer, we're not talking about CIN2 or 3. CIN2 or 3, those follow-up recommendations are included in the ASCCP 2012 guidelines. For true cancer, Your oncologists are probably going to be managing her follow-up, and MCC does those guidelines. But keep in mind, in all likelihood, as treatment for cervical cancer, she will have had her cervix removed. A couple of key points in regards to ASCCP. I know I went through this data very quickly. There are several resources ASCCP offers. One is their app for your phone. It's a great app. It's well worth a few dollars. I think it's under $10 that it takes to purchase. If you are doing PAPs frequently and having to make clinical decision making about it, you need this app. It's very functional. It's very easy to utilize and really breaks those logarithms down. You can enter the patient-specific information and follow her through each step as to what to do next. They also offer some e-learning. So I know I went through this data very quickly. Their e-learning modules go through it in much more depth and much more explanation of the data and how the data is interpreted into clinical guidelines. Finally, ASCCP offers the only national certification that's accepted in regards to both colposcopy and anoscopy. So both of those are offered as a didactic course for 3 days. And then for colposcopy specifically, but not anoscopy, there's a follow-up mentorship available as well as an exam that if you complete both of those components and successfully pass, then you are provided an additional certification in colposcopy. All right, so let's spend a couple of minutes talking a little bit of specifics about two populations, particularly lesbian population, and then our more focus on our female to male transgender. So just like we looked at earlier, you know, thinking about who's infected with HPV, lesbian women are not less likely to be infected with HPV than any other woman. There are some studies that show possibly that there's increased prevalence, although remember, when we're talking about 50 to 80% of the population is infected with HPV at some point during their lifetime, then, you know, whether lesbians are more likely than heterosexual, I'm not sure that I could totally support that, but the studies that were done looked at short periods of time for these women. In transgender individuals, again, this is no different. HPV infection affects us all. However, there are a couple of key points and why these two groups have been less screened than others, and that you in fact do still see continued persistent increased prevalence in both lesbian populations and transgender in regards to actual cervical cancer, and it has to do with their access to screening. One of those issues is that us as providers have often sort of misinformed lesbian couples and women that they're not at increased risk or that they even don't have a risk for cervical cancer, and that is simply not true. But even fairly recent research in the last 10 years still shows that that was occurring and has been occurring, and we definitely need to change that. The other thing has to do with access. So we know, again, that publication in Justice at Every Turn demonstrate quite clearly that transgender and lesbian and other sexual and gender minorities really suffer from lack of insurance access that is tied to a lot of socioeconomic factors. Finally, for lesbian population discrimination, and if you look at transgender population, even violence happening at clinics when they've tried to access health care. And that can certainly deter people from seeking even routine screenings with things like PAPs. All of these things kind of work together to mean that we see sexual and gender minority folks are screened less often, and that they're often later in cervical cancer progression before it's detected and treated. For transgender specifically, you want to remember that the majority of transgender men do not undergo genital reconstructive surgery for several reasons. One is, again, that access and cost issue, but another is sometimes they simply choose that's not the route for their trajectory of transition. You know, it's unfortunate that many guidelines kind of exclude transgender individuals, and many transgender individuals, because they think of themselves as men, and that is how they identify, they really don't want to think about the parts of them that may still need female-type care. You can certainly have some dysphoria and a desire to really ignore this part of their body. And then also the testosterone, if they are on hormone treatment for transition, can do a couple of things. One is that it increases vaginal atrophy, so drier skin cells, which have two impacts. One, that the Pap itself may be more painful. You may consider allowing self-collection of Paps, and we go into more depth in that in the second module I talked about earlier, but also increased likelihood that you're going to have unsatisfactory, so not enough cells on the Pap sample for the pathologist to make a determination, which of course unfortunately means we have to do a Pap more frequently. I do highly encourage you, if you're going to be providing care to transgender individuals, that you do seek out extra training not only for yourself as a provider, but also for your staff. So it's important from the people who answer the phone all the way to the back staff, to the provider themselves, that they are addressing needs of transgender individuals in an empathetic and professional way. One of the organizations not listed here, and I'm sorry for that, is the Health Equity Institute. They actually offer trainings on an annual basis that's done webinar style, and if your clinic participates in them with your staff, and the trainings are appropriate for staff at all levels. There's certainly clinical knowledge for providers, but there's also more basic 101. The Health Equity Index will provide a certificate to clinics that keep up with that training for their staff. These are some inclusive counseling strategies, and I'm going to move quickly through here because I do want to get to our case study. And here's a nice quote from a trans individual who said, "We need our options at least explained to us, even if we ultimately decline the Pap." You can read through these slides on your own as far as they are available on ARHP's website. In regards to our case study, this was built around a patient that I cared for, 23-year-old, works in retail, started hormones about 2 years ago, and is transitioning nicely, has had a new relationship with a female partner, and comes in specifically because she really said, look, you've got to go in and talk to Nicole about your Pap. I've had some abnormals in the past, and I'm just really worried about this, and I don't want you to not get screened. And he had been in that relationship for about 6 months. He had never had a relationship with a male partner at all. He'd never had a cervical screen. He was a prior smoker, and over time, getting to know him, we had worked through smoking cessation. Again, that's one of those behaviors that it's important to spend time counseling and may, in fact, reduce that chance for cervical cancer. And he'd never received the HPV vaccine. So things that you want to be thinking about are things about his Pap, whether or not you need to do HPV testing, think about his age for that, whether there's other STIs you need to think about, and whether there's other health recommendations. These are some things that you can counsel him about and provide education about. So yes, that HPV vaccine, he's still in the correct age category at age 23. So remember, for natal females, he can get it all the way up to age 26. For that history of smoking, you want to continue to give positive reinforcement to stop smoking. Today, and I will say this is very common, you'll often counsel folks, and it's important to provide that counseling in an empathetic way and to recognize the dysphoria it may cause. You can offer some things such as an anti-anxiety medication on a single dose for the day of the Pap. That certainly has worked well for folks. It's not a long-term dose. It's a single day. They do need to have a driver if you're going to do that. He wanted to come back at another time when he could have his girlfriend accompany him. Other things are things like music, and even simple things like having blue gowns instead of pink gowns is one of the pearls that our transgender participant in our podcast mentioned was meaningful to him. Letting folks listen to music through earbuds, dimming your lights in your room. And finally, one thing that I find works very well for both my transgender folks, but also for my women, is let them wear their cowboy boots or their cowgirl boots. You know, somehow if you have your boots on, you can't quite be so naked. By the way, there's no data supporting that, but that is Nicole Gettings only. I will say that. Our patient does return. He comes back. He gets his Pap. He does want that vaccine at that time. And here's our results. And we want to be thinking, when is that next Pap needed, and when is his next HPV vaccine. All right, and I think that we're right at an hour, and I'm not sure if we're going to take a couple of questions or if we need to wrap up.
Great. Thank you, Nicole, for that excellent presentation. I will now read a couple of questions that we've gotten throughout this webinar. The first one is from Barbara, and she asks, why are 2 doses recommended for 9 to 14-year-olds while older adolescents need 3 doses?
Yeah, so I'm sorry I had to cover that information so quickly. I do highly encourage you to go back to the ACIP recommendations that released December 2016. Those can be found at the CDC website, and read through those. But it has to do with our immune response, and there was an age cutoff. So under age 15, that immune response was as effective, as robust, with only 2 doses. But after age 15, that immune response was not as robust without the 3rd dose. So again, you know, I do encourage you to go back and read those guidelines for more explanation.
Great, thank you. Our next question comes from Grace, who asks, what immunocompromising conditions warrant 3 doses given to 9 to 26-year-olds?
Yeah, so that's a great question. So if you are very familiar with ACIP recommendations and vaccines in general, you'll know that often when a vaccine is initially released, they don't have data, and they will say this in ACIP recommendations, that we don't have data on the immune response of immunosuppressed individuals. We suspect that their immune response may be less than non-immunosuppressed individuals. So that's usually their first recommendation. For the HPV vaccine, they did eventually start to get that data, and I believe that data started in the 2009, but I'd have to look it up to be sure. It may be the 2011, when they actually started to get that data. And that data has continued to show that 3 doses is needed for that robust immune response in immunosuppressed individuals.
Great, thank you so much. Our next question comes from David, who asks, how accurate are Pap results from patient self-collection?
That's a great question. So there's a caveat answer to that. So one is that in transgender population, there aren't any studies specific to transgender with self-collection of Pap. However, I've been watching this self-collection of Pap for a long time. I've used it very occasionally in the clinic because of necessity sometimes, because it was the only way that I could get a Pap. I will tell you that the Pap results I personally have gotten are excellent. And then just in the last 2 years, there's been several studies released on use of self-collection of Pap, and they do show validity with self-collection being pretty much as good or nearly as good as provider collection, which is very interesting. But that's definitely going to be a topic we're all going to be tuning into. There are certainly populations that are harder to reach that are already being studied in regards to this. But then I think eventually we're going to be asking ourselves, for all women, is it possible that a self-collected Pap may be an option we need to be offering, similar to how we've seen that transition with GBS testing.
Perfect, thank you. Nicole, at this point, would you like to review the key points for the participants?
Sure. So again, cervical cancer we know is related to persistent HPV infection, and we know it takes those other things, time, you know, cofactors, specific genotype, and location to result in that outcome. Data has supported a revision of the screening guidelines to correlate with a woman's age and clinical history, and we went through some of those today. We can sometimes use genotyping, but only in specific populations, and we can sometimes use HPV high-risk versus low-risk testing. Again, we need to make sure we know what test is being utilized. After age 65, a woman can exit. And then for our sexual and gender minority populations, they really face some specific unique challenges, and really it's up to us as providers to make sure that these folks have access to care just like everyone else.
Perfect. Thank you again for joining us, Nicole. Before we end today's webinar, I'd just like to share a few important reminders. Please visit arhp.org to view a recording of this presentation and to access the full slide deck on course. Please also be sure to mark your calendar for the next webinar in the cervical cancer series taking place on February 23rd. Registration will open on arhp.org within the next week. As a reminder, you will receive an email from Caitlin Borsowitz in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser. If you have questions, please email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.